Good evening, everybody. Welcome to another insightful session of our core masterclass in nephrology. Today's topic being renal transplantation in a sensitized patient with a distinguished faculty from the city of Joy, Kolkata. Our examiner today is Dr. Pratik Das from RNT Hospital, Kolkata, senior nephrologist, with his presenting student, Dr. Amar Pratap Singh. Discussant, Dr. Arpita Roy Chaudhury, Professor in HOD, NBMCH Darjeeling, IPGMER, Kolkata and Manipal. And our most respected expert for the session, Dr. Vinay Sakhuja from Max Mohali. Again, I thank my conveners, Dr. Vijay Kher and Dr. P P Varma, for giving us this opportunity and hand over the session to them, sir. Thank you.
Thank you, Puneet. Thank you, and good evening, friends. We are back again, and today, as Puneet was mentioning, we have got a very interesting case. That is, the approach we are taking, how to go about in a patient who is sensitized and you are heading for transplantation. As you mentioned, Professor Pratik Das, a very learned, very senior nephrologist from Calcutta, and a very uh, firm person who is a keen researcher and teacher. He is the examiner today, and the discussant is Professor Arpita Roy Chaudhury. She is again a very senior and learned nephrologist, loved nephrologist. She has been heading the Calcutta SSKM hospital. Then she moved to Darjeeling, and she's back to Calcutta almost. What is important, she is president of Indian Society of Organ Transplantation, and she is leading figure in the field of women in nephrology. And it's a pleasure always to listen to her. She is the discussant today. And expert is the doyen in nephrology, my teacher, my respected teacher, Professor Vijay Sakhuja from Mohali. And he'll be the expert for today. My colleague, Professor Vijay Kher, and myself, we are there to moderate the session. Professor Vijay Kher is in US and he will be joining from there. Maybe because of the time schedule, he may take a minute or two extra to join. The student today is Amar Pratap Singh. Dr. Amar Pratap Singh is student of Professor Pratik Das. He is a final year DNB student. Before I go further, I'll request Professor Sakhuja to say a few words and then he can initiate the session.
Thank you, Professor Varma. It's a pleasure to be with all of you to listen to this presentation and discussion. So, I'd just like to introduce the subject of a sensitized recipient very briefly. So, this is one of the most challenging situations in which a transplant is attempted, and it's an area of still of great controversy as to whether one should accept such donor recipient pairs where there is a significant amount of sensitization, because the long term outcome of the transplant remains quite uncertain, unpredictable. And even dealing with the complications that occur in these patients is not only difficult, challenging, but also very costly. And therefore, these are the questions that we will try to answer during the course of this discussion. I think we can now go ahead.
Yeah, since Professor Kher, I'm not sure whether he will be able to join or not, or he joins late. I'll request Professor Sakhuja that he is moderator come expert today.
Fine, no problem.
Please, Dr. Amar Pratap, you can go ahead.
Yes, sir. So is my screen visible?
Yeah,
Yes.
that's all.
Okay, sir, I'm starting. Good evening, respected faculties and my dear colleagues. Today, I am Dr. Amar Pratap Singh. I'm a DRNB trainee from RNT Hospital, Kolkata, and I'll be presenting a case today. So my patient, Mr. X, he is 53 years old male from Shantiniketan, Bolpur, West Bengal. He is Hindu by religion. He is educated till MSc in physics and works in PWT department of Government of West Bengal. He is married for last 27 years and history has been given by the patient himself and is reliable. The patient was admitted on 10th August 2025 and was examined by me on 12th August 2025. So my patient is a known case of hypertension for last 25 years and he is status post living donor near related AVO compatible renal transplant recipient in January 2025 and has now presented to us with the following complaints: slowly rising creatinine over last 6 weeks and pedal edema for the last 3 weeks. Coming to history of present illness, I would like to date back my history to June 2000 when the patient was 28 years old. He had an episode of fever for 3 days. The fever was high grade, intermittent, and associated with generalized body ache, dry cough, and running nose. He was treated for respiratory tract infection with oral antibiotics and his fever subsided. He was also advised to do routine investigations which showed a creatinine of 1.6 milligram per dl. He was then advised to repeat his creatinine and do ultrasonography of abdomen after 2 weeks, which again showed a creatinine of 1.6 milligram per dl and USD showed multiple cysts in both his kidneys. His blood pressure on both the visits were high, 150 by 90 mmHg. He was started on tablet amlodipine 5 mg and atenolol 50 mg once daily and was advised to consult a nephrologist. Our patient then visited a nephrologist in private hospital in South India, and after evaluation, he was told to have polycystic kidney disease and advised to have strict BP control and to be in regular follow-up. However, for the next 10 years, he did not follow up with any nephrologist, nor did he do any blood investigations. In 2010, he consulted a physician locally and found that his creatinine has increased from 1.6 to 3.6 milligram per dl and his BP was 170 by 90 mmHg. Following this, he consulted a nephrologist in Kolkata and his BP medications were optimized. He was again lost to follow-up for the next 6 years. In 2016, his creatinine has now increased to 4.9 milligram per dl and his BP on this visit was also high. He again did not consult any doctor for the next 6 years. In the meantime, he had stopped all his blood pressure medications for 3 years from 2019 to 2021 and he had started Ayurvedic medications for his BP and kidney problem. In 2023, he consulted a physician locally for complaint of shortness of breath and palpitation on exertion and on evaluation was found to have a creatinine of 7.9 milligram per dl and hemoglobin of 6.4 gram per dl. He then attended our hospital for further management. After evaluation, he was given 2 units blood transfusion. His blood pressure medications were restarted and he was also given some weekly injections to increase his hemoglobin percentage. Throughout this course of history, there is no history of reddish or cola colored urine, jaundice, any NSAID intake, any black stool, any abdominal pain, recurrent urinary tract infection, any rash, joint pain, any thunderclap headache, any visual disturbances, any weakness of facial muscle or limb, any chest pain, any history of awakening from sleep due to shortness of breath, or any history of passing of stone through his urine. He was then advised to create an AV fistula and further planning for renal replacement therapies were discussed with him and his wife. He underwent AV fistula creation in his left forearm in June 2024. In October 2024, his creatinine had increased to 9.3 milligram per dl and he had uremic symptoms in the form of nausea, vomiting, decreased appetite and generalized weakness. He was initiated on hemodialysis through his left forearm AV fistula, initially at 2 per week for the first 1.5 months and then increased to 3 per week thereafter. In the meantime, he underwent workup for living donor ABO compatible renal transplantation. Donor being his wife, who is a 50 years old female with no known comorbidities, and her blood group being O positive, and blood group of our patient was B positive. HLA mismatch was 10 by 12. In view of massively enlarged kidneys, he was advised to undergo bilateral nephrectomy before renal transplant surgery. In December 2024, he underwent bilateral nephrectomy. However, Post nephrectomy, he required multiple blood products transfusion. PRBC, FFP, and platelet were all given, and he had prolonged ICU stay in view of collection of blood in abdomen. Upon stabilization, he was discharged and advised for readmission after 2 weeks for renal transplant surgery. During workup, his cross-match test came positive. In CDC, B cell was positive, and in flow cross-match also B cell were positive. Following this, he underwent a costly test to look for antibody levels against the donor, and that too was positive. SAB Luminex was done, sir, and it was positive for HLA-DQ, and MFI was around 8,000. He was then admitted on daycare basis, and a costly injection was given for 4 hours. And he was also started on 3 medications, namely tacrolimus, mycophenolate mofetil, and prednisolone, and was advised for admission after 7 days. After admission, after 7 days, he underwent plasma exchange on alternate days, and another costly injection was given to him on alternate days over 4 to 6 hours. After 5 sessions of plasma exchange, his cross-match test was repeated, which came negative. CDC flow T cell cross-match were negative, and SAB Luminex was again done, which showed decrease in MFI from 8,000 to 1,400. After all clearances, he underwent living donor near-related ABO-compatible renal transplantation on 12th January 2025 with immediate urine output post-surgery. He remembers that 2 costly injections were given to him, one the night before surgery and another injection was started before OT and then given again on the next day. Induction agents that used were methylprednisolone and ATG. Till POD 5, his graft function was good and his creatinine was 0.9 mg per dl and urine output was around 5 liter per day. On POD 6, his creatinine started to rise from 0.9 mg per dl to 1.9 mg per dl, and urine output had also dropped from 5 liter per day to 2.2 liter per day. He was given high dose steroid and simultaneously graft biopsy was done on POD 7. His graft biopsy was suggestive of rejection, antibody mediated rejection, for which he was again started on plasma exchange, and the same costly injection which was previously given to him in pre-transplant period on alternate days were given again. Now in the meantime, his creatinine had increased to 5.6 mg per dl and urine output had decreased to 1.2 liter per day over the next 2 days. After 5 sessions of plasma exchange, his creatinine started decreasing and urine output improved. He was then discharged on POD 9 after DJ stent removal with creatinine of 1.3 mg per dl and urine output of around 4.5 liter per day. Over the next 5 months, he was followed up in OPD, where he had 2 episodes of UTI, which were treated with oral antibiotics. His creatinine had remained stable around 1.3 to 1.4 mg per dl, and tacrolimus level were within the advised range. He has now presented to us with complaint of slowly rising creatinine from 1.2 mg per dl to 2.9 mg per dl over 6 weeks and swelling of both feet for last 3 weeks. There is no history of fever, cough, shortness of breath, loose stool, burning micturition, painful urination, decreased urine output, reddish colored or frothy urine, drug incompliance, alternative medicine intake, tremors, or weight loss. He underwent graft kidney biopsy on 11th August 2025 and awaiting its result for further plan of treatment. Coming to past history, he is hypertensive for last 25 years. He is non-diabetic. There is no history of tuberculosis in the past. There is no history of any cardiac or neurological disease in the past. He has masters in physics. He is a government employee. He is chronic smoker, being 15 pack years. He is non-alcoholic, has normal sleep and appetite, regular bowel and bladder. Family history, there is history of kidney disease in his family. His father died at 56 years of age due to ICH and was diagnosed to have polycystic kidney disease during this hospitalization. He required 3 sessions of hemodialysis before passing away due to ICH in the same hospitalization. His elder brother had ADPKD and had progressed to end-stage kidney disease by 54 years of age and underwent renal transplantation at 56 years of age, and he is currently doing fine. Younger brother and mother are normal. He has 2 sons, 16 and 18 years. Both of them are normal. Surgical history, as mentioned, he had underwent bilateral nephrectomy in December 2024 and living donor near-related renal transplantation in January 2025. Drug history, the patient is currently on capsule tacrolimus 2 mg twice daily, mycophenolate mofetil 500 mg twice daily, tablet prednisolone 10 mg once daily, and tablet cilnidipine 10 mg twice daily. Dietary history, he consumes mixed vegetarian and non-vegetarian Bengali diet. He belongs to a upper middle class family, lives in a 2 BHK Pakka house with 2 separate toilet and kitchen. So this is my history.
One question, Amar.
Yes, ma'am.
You have gone for a biopsy. Did you send any other non-invasive investigations to support your differential?
Yes, ma'am. The patient was admitted on 10th August. He underwent biopsy on 11th August, and that I have mentioned in the history, ma'am. And I have examined the patient on 12th August. Other than this, he had also undergone
No,
investigation.
any other investigation
Yes,
other
ma'am.
than biopsy to support your diagnosis?
Yes, ma'am. He has undergone his routine investigations, urinary. He has undergone USG graft. He has also undergone urine examination and also
Any other
undergone.
immunological?
Yes, ma'am. He has undergone SAB undergone, ma'am. DSA SAB Illuminex, ma'am.
Yes. That report is also not available with you?
Ma'am, report is available now, ma'am.
Okay.
So just to summarize what you have told.
Yes, sir. So coming to summary, my patient, Mr. X, 53 years old gentleman, known case of hypertension, ADPKD, status post bilateral nephrectomy in December 2024, underwent living donor near related ABO compatible renal transplantation with history of desensitization in the pre-transplant period and rejection, likely ABMR in the immediate post-transplant period in January 2025, has now presented to us with history of creeping rise of creatinine for the last 6 weeks and pedal edema for last 3 weeks.
So for this patient, what was the special concern for before doing a transplantation for this specific patient? What was your special concern in the transplantation procedure?
Sir, he was sensitized, sir.
Okay, he was sensitized. One,
He was
what do you mean by a sensitized patient?
sir, he had history of blood transfusion twice. One in 2023 and another during nephrectomy. He received multiple blood products, sir.
So one is
Yeah,
history.
Amar, can I say
Yes, sir.
something, Dr. Pratik? Hi. Sorry for joining late. I'm in US. So, Amar, I
Yes, sir.
wanted, do you do bilateral nephrectomy in every patient of ADPKD before transplantation?
No, sir.
Yes, I had in fact already noted down this question for asking later. Please go ahead.
Sir,
Yeah.
he had hugely distended kidneys, so our transplant surgeon decided to go ahead with bilateral nephrectomy
Yeah,
to create space.
actually, over the last 25 years,
Yes.
previously we used to do either a single nephrectomy or a bilateral nephrectomy. But over the last 25 years, we have rarely, probably one or two nephrectomies which we may have done. And the reason for not doing nephrectomy, because you will find always space,
Yes.
because these are retroperitoneal masses, whereas when you do the kidney transplantation, you do an extraperitoneal on the anterior side.
Yes.
By and large, we have not found any need to do nephrectomies, and we were able to do transplantation either on the left or the right side, depending on where the space was available. And by and large, you are able to get this space. And I think he became sensitized predominantly by multiple blood transfusions that he received post-transplantation and post-nephrectomy. And that's what happens most often. In patients, when you do bilateral nephrectomies, it's difficult to maintain their hemoglobin. So
Yes.
I think by and large, what was taught in the books and what was practiced earlier, if you're a surgeon, you are able to, and if as a nephrologist you feel, I know you are not a surgeon and you don't have to do the surgery, but if the context between and the contact and the understanding between the surgeon and the nephrologist is good, you might be able to convince the surgeon to do the surgery without nephrectomy. And many of our patients, most of our
Yes.
patients these days, we rarely find a reason to do nephrectomy. Tell me other reasons. One is space. When would you do nephrectomy, either single or bilateral nephrectomy in a patient with ADPKD, where it may become necessary, other than the space?
So other than space, we can consider bilateral nephrectomy. The patient is having persistent cyst infection, severe pain, not controlled with medical or surgical intervention, recurrent renal stone. Sir,
All right. So, Ajay Pratap, I think I fully agree with what Dr. Kher was talking,
yes, sir.
that we have also practically never done. But what I'm saying is, it sometimes it becomes imperative. Right now, I have got a patient who has got bilateral, of course, ADPKD, and his abdomen is full. By ultrasound kidney size given is 32 centimeter each side, but it is huge. And logically, the surgeon can't find a space. So I'm sure Pratik must have done that before. And
Yes, sir.
since there won't be any space, that is why. The other question will be, why bilateral then? If we was to do a transplant, why bilateral? Why not single?
Yes, sir. Single side nephrectomy could have been tried in this patient, sir.
Yeah, because that is, if you have to, suppose there is no
Yes, sir.
space, it is totally, sometime it occurs. I have got right now patient admitted, you can't find any space. Surgeon tries his best. So, but if you are doing it, preferably do a single one, single nephrectomy, because right side where you have to place it.
Yes, sir.
Now,
Why? What is the advantage of a single over a bilateral nephrectomy?
Sir, nephrectomy per se is a complicated procedure, sir. So decreases the morbidity and mortality with single side nephrectomy, sir.
No, how
Plus also,
exactly?
sir, it also other than this, sir, it keeps the residual renal function of
Yeah,
the.
that's the important thing.
Yes,
So if you do only a unilateral nephrectomy and the patient is passing urine,
yes, sir.
so he still continues to pass urine after the unilateral nephrectomy. Whereas after a bilateral nephrectomy, he'll become anuric,
yeah,
Yes, sir.
and you may require more frequent dialysis also to maintain the patient until the time the transplant is done.
Yes, sir.
So that's another important thing to remember.
that's right.
And there usually will be a gap of maybe 1 or 2 weeks in between the nephrectomy and the transplant.
Yeah.
Yes, sir.
Second, since you are on ADPKD, you said the patient was started on amlodipine and epinol for
Yes, sir.
hypertension control.
Yes, sir.
What will be your choice? And you said strict blood pressure control. What
Yes, sir.
you will imply with strict blood pressure control in ADPKD?
Sir, I would have started AC inhibitor or an ARB, and blood pressure target would have been less than 110 systolic, and diastolic would have been less than 75 mmHg, sir.
Good, good, good.
But I'd like to comment on that.
Yeah.
Uh, Dr. Amar,
Yes, sir.
the targets that you mentioned, the blood pressure targets, you said what? Can you just repeat?
Sir, systolic of less than 110 mmHg and diastolic of less than 75 mmHg.
At what stage? You're
Sir, this is
talking
for
of when the patient is on dialysis?
no, sir. This is for patient when they are in G1 or G2 and age of less than 50 years.
Hmm. And which guidelines are you quoting?
So I'm quoting KDIGO, sir.
KDIGO.
Yes, sir.
Have
This is
you
the
have
halt
you read
PKD.
have you
Yes, sir.
read
Halt.
the differing views on this?
Sir, some guideline.
Does everybody agree with this such a strict blood
No,
pressure
sir.
control?
No, sir.
I
Some
don't, at least.
no, sir. Some guidelines mention a systolic blood pressure of around 120 mmHg, sir.
See, these guidelines are based on the SPRINT study,
Yeah.
the SPRINT protocol. If I'm sure you must have read about that study.
Yes, sir.
And the KDIGO has gone by those guidelines.
Yes, sir.
However, if you look at guidelines by the other European and American associations. They don't agree with this. They feel that this is
Too strict.
very
Too
this is
strict.
very strict blood pressure control, very likely to lead to hypotension, very likely to lead to falls, particularly in elderly patients, and can even cause AKI.
Yeah. Yeah.
Yes.
So therefore, this may be all right in the guideline, but I don't think it is
Practically, yes, sir.
practical.
Yes.
I would also agree that probably a guideline of about keeping blood pressures to about 130/80 and so would
Yeah,
be a
that 130/80
reasonable,
is
That is
would be
absolutely
a
fine.
reasonable, yeah,
recommendation. Yeah.
reasonable.
Because though
So
KDGO mentioned, as Professor Sakhuja said, based on sprint,
120.
but it is very difficult to achieve. And if you are achieving it with a lot of morbidity. But I think Ajay Pratap, Amar Pratap
Amar,
mentioned because of HALT PKD trial, which
yeah,
HALT PKD trial 1 and 2 were done,
Yes,
they
sir.
yeah.
they had targeted 110/70. So possibly he's bring it is not AD what you said, it is not a KDOGI guideline. KDOGI
Yes.
guideline
That's
is
a,
different.
is an
That is
halt.
126,
Yeah, it's a,
70, 80. This
Yes.
is HALT PKD trial, what you were mentioning.
Okay. So your one concern is your polycystic cystic disease of the kidney or the polycysts. What was
Yes.
the other concern in this patient? Because your cyst nephrectomy blood transfusion may fall in the one line. But what was the other concerns when we are planning for a transplantation, particularly this patient? You told there's a family history positive, and
Sir,
in that
yes, sir. Family history is positive. So selecting a donor, sir, is another concern, sir. Donor from family.
in which situation you look for an extrarenal manifestations mostly in a patients of AD?
Sir, specifically if the patient has a family history of any, sir, any subarachnoid hemorrhage or
So, what is the incidence of these intracranial aneurysms if there is a family history versus if there is no family history? What is the difference, and when do you look for that? Because this patient has a family history of
sir,
IC in his
yes, sir.
father.
Yes, sir. So the normal incidence in general population is around 3%. Sir, in ADPKD, the incidence increases around 8 to 15%, sir. When
So
there is a
one
family, yes, sir.
family. And I mean, which other situation that is applicable for this patient also, where you need to screen for an aneurysm?
So we need to screen if there is a family, if there is a sir, death in a family member which has without any cause, then we need to screen. If there is a family history of subarachnoid hemorrhage in the family member, then we need to screen. And if our patient itself is having any symptoms, then we need to screen. Also, if he is undergoing transplantation, we need to screen, sir.
Yes. Whenever you are planning for a planned surgery, like
Yes,
this,
sir.
a transplantation, maybe a valve replacement surgery.
Yes, sir.
So in these situations, you must inquire for. So this patient probably required a pre-transplant evaluation of that also.
Yes, sir. He got done, sir. MRI.
That fatal complication in the post-operative field.
Yes,
So
sir.
in your patient, what do you think? What is the cause of sensitization in this patient?
So my patient has received blood products twice, sir. One in 2023 when his hemoglobin was very low, and he was symptomatic, having shortness of breath and palpitation. And again, post nephrectomy, he received multiple blood products. So that likely is the cause of sensitization, sir.
Other than these, what might be?
Yes, ma'am. Sorry.
Other than this transfusion of products, what might be? Who is
Sir,
his donor?
his donor is his wife, ma'am.
So you told that this is a blood and blood product transfusion. So
Yes.
what are historical events that you inquire before telling a patient sensitized, and how? What is the difference? Is the all bloods and blood products the same to cause a sensitization? Suppose the patient, yes.
No, sir. Sir, mainly, sir, mainly red blood products and FFP, sir, are more likely to cause sensitization, sir.
So suppose this patient received a PRBC, that is RBCs.
Yes,
He
sir.
received FP, she received the platelets, and depending upon their antigenic potential and induced sensitization, can you grade
Yes.
them in order, which is least and which one is most?
The platelet is least, sir. FFP is most.
No, it's not like that. Because your RBCs, because where the class 1 antigens are present and class 2 antigens you have to do. So RBCs are
RBC,
the
sir.
antigens because they per cell, they only 20 to 100 and HLA antigens are there, that to class 1.
Yes,
Okay. And
yes,
also this is for a platelet is quite antigenic. That is important. You are told that the blood platelet, blood products. Platelets contain huge amount of the antibody, that is around 10 to 50,000 per platelets, and even
okay,
50
sir.
transfusion may cause a more sensitization. Okay, and rather
Okay,
not only that, it also shades the antigens in this. And
okay, sir.
plasma, that doesn't contain any cell. How can they be sensitizing? How do they sensitize? They also contain this shaded. This is
Shaded, sir.
shaded by platelets, lymphocytes, and they remain in the plasma. So they are also antigenic. Although
Yes.
lymphocytes carry more than 2 lakhs antigen per cell, they are most antigenic. RBCs are least antigenic. RBC, plasma, platelet, and the leukocytes. Okay.
Sir.
So
Okay, sir.
if to transfuse this patient, you could have been avoided this platelet transfusion and the plasma transfusions. Only PRBC, okay. This is least antigenic and then cause a least sensitization. So is there any way to prevent this? Because in other cases, retransplantation, in pregnancies, you can't do anything. That has happened. But this transfusion is in your hand.
Yes, sir.
So what are the ways you could have been taken for this patient to prevent the sensitization?
Sir, leukocyte depleted blood products could have been given, sir.
So how do you order that? How do you do that with the leukocyte depleted blood, and how effective it is?
Sir,
You can order to the blood bank where the cell separator is there.
yes,
They
sir.
can separate and they can bring, that is more effective.
Yes, sir.
And if you do the leukolipid filter, that is called the post filter type, that
Yes,
also can do that. But that cannot prevent,
yes,
because because they also carry quite good amount of the WBCs, even the NK cells they goes into, and the cells goes there. So it is not a preventive measure. Once it was practiced, still we do practice, but it doesn't prevent the sensitization.
yes,
Okay. So one thing you could have been done in blood transfusion, only avoiding the blood products, other products transfusion, and secondly could have been using leukodepletion type of. So this patient developed antibodies after this blood transfusion and
yes.
blood transfusion. Okay. So how did you know that this antibody is developed? By testing what?
Sir, by doing cross match, sir.
So how do you detect there is an anti-HLA antibodies are developed? What are the preformed antibodies you know?
Sir, sorry, sir, I did not get your question. Preformed?
What are the types of preformed antibodies you know that makes a patient sensitized? Sensitized means patient is having antibodies to some
Yes, sir.
antigen adversely affect post-transplant.
Yes, sir.
So one, suppose this is an anti-HLA antibodies. What are the other
Yes.
antibodies?
Sir, can be anti-HLA, can be non-HLA antibodies, sir.
Yes. And also ABO antibody.
As neo antibodies, sir.
Yes. So how do you test that? In your patient,
Sir,
how did you do that?
Sir, we test first for complement-dependent cytotoxicity cross-match and flow cross-match. For my patient, both CDC B cell and flow cross-match, B cell cross-match were positive. Then we proceeded for sir SAB testing for detection of donor-specific antibodies.
Yes, sir. You have done this SAB test, single antigen bead
Yes, sir.
testing by Luminex-based assay.
Luminex-based assay, sir.
Okay. Once you do this DSA and the CB, what informations you get, and that might be helpful in this patient also in selecting a patient this as for transplantation.
Sir, from DSA we can get the MFI of the MFI of the donor-specific antibodies. So if we can calculate the relative intensity score, if it is more than 17, we will likely avoid transplanting this patient, sir.
Only that. What are the other things you get? By suppose you are getting, you have told your MFI.
Sir, we can, yes, sir. So we can get which type of antibodies are positive, whether it is class 1 or class 2. Class 1 is relatively easy to desensitize compared to class 2. In class 2, whether it is DQ, DP or DR, DQ is relatively, sir, tough to desensitize, sir.
Why it is so? Is it class 1 is easy to desensitize? And is it the only antibody that is important, or also the memory is also important?
So the memory is also important, sir. The plasma cell have a memory, and they may post-transplant form the donor-specific antibodies, which may result in complications, sir.
I think we can proceed ahead. What was the antibody titer here?
Sir,
what was the titer?
So
sir, he was positive for HLA DQB1, and the titer was around 8,000, sir.
Titer was?
8,000. 8,000. MFI was 8,000, sir.
Okay.
Yeah, initially was 8,000, then with plasmapheresis came down to 1,400 before you transplanted him, isn't it?
Yes, sir. Yes, sir.
Yes, sir. What is the titer? Have you done a repeat titer now?
Sir, we have done a repeat titer now. It is around 4,000, sir.
So it's gone up.
Yes,
so
sir.
around 4,000. Is it the same antibody or is it a different antibody?
Same antibody.
There was one antibody or multiple DQ antibodies?
Sir, it was only DQB1, sir. There were other
DQB1.
antibodies, but were not donor specific.
They're not donor specific. So donor specific was MQB1.
Yes, sir.
And
DQB1.
B1. Okay. So we don't have the titer. You said it's 4,000 now. So
yes, sir.
What's the biopsy? Biopsy, we have done the biopsy, but you're going to discuss that.
Sir, biopsy, it is a chronic active ABMR.
Are you discussing with slides?
No, sir. Sir.
Okay.
Biopsy slides we do not have, sir.
Okay. You don't have the biopsy slide. So this is a chronic active.
This time it is chronic active ABMR, sir.
ABMR.
Okay.
So what's the difference between active ABMR and chronic active ABMR?
Sir, active ABMR, sir, it is by Banff classification, sir. In active ABM, active ABMR, there is glomerulitis, there is peritubular capillaritis. In the along with that, there is transmural arteritis or intimal arteritis in the histology. And in chronic active ABMR, the histology, it is, sir, doubling of the glomerular basement membrane or multilayering of the peritubular peritubular capillaries basement membrane. This is the histological difference, sir. And in chronic active ABMR, there is some form of chronicity as well, sir.
So what does it tell you clinically? What information does it tell to the clinician?
Sir, that the patient has been undergoing some form of rejection for quite some time, sir. That has resulted in chronic active ABMR, sir.
What's the response to treatment in active ABMR and acute active ABMR and a chronic active ABMR?
Sir, the best response is patient respond best if they have a preformed DSA. Then there is then the next is when they have a de novo DSA, and the worst response is in chronic active ABMR, sir.
Worst is in chronic active ABMR. Okay.
So how did you manage? Let's ask you. You have managed that.
Yes,
initially, desensitization protocol you adopted. You
Yes,
did plasma exchange and IVIG. Was
sir,
that?
we gave rituximab 14 days before admission. 7 days before transplant, we admitted the patient for plasma exchange and IVIG. And after 5 sessions of plasma exchange and IVIG 10 gram post plasma exchange for 5 doses, his cross match was repeated and taken up for transplant.
Okay, so This was a low dose IVIG regimen.
Yes, sir. Low dose IVIG regimen.
Is there any scope of what people do desensitization? Some people choose plasma exchange, some people choose DFPP, some choose immunoadsorption. Any
Yes.
comment on that?
Sir, the amount of plasma removed is the amount of plasma exchange is maximum with plasmapheresis, and the amount decreases significantly in DFPP, and the use of blood products also decreases. And in immunoadsorption, there is no the same plasma is returned back, and the antibodies are absorbed,
I'm
sir.
not saying.
So,
I say, is there any selection of patient
yes,
that
sir.
this patient I want to do immunoadsorption,
Sir,
this patient
very
I want to do DFPP, this patient I want plasma exchange?
Sir, very high titers are preferable for immunoadsorption, sir.
Okay. Any Pratik, your center, because some people feel that if the titer is, or let's say 9,000 to 12,000, you go for DFPP. If it is below 9,000, plasma exchange is valid. Any comment on that, Pratik, your center?
We have never practiced, sir, because we are not very much aware why this DAPP filter, because they have stopped producing this. An absorption column is there, but we don't have any experience. We always do plasmapheresis, maybe increase a bit number, more or less. We don't practice. But it is said that, yes, it is a good if the titer is high, then you can change more volume of the plasma by the double filtration of the absorption. But we don't
Yeah,
practice.
Yes, sir.
What is the outcome? Doing all these procedures of desensitization, whatever you have,
Yes,
what
sir.
is the outcome, short-term and long-term outcome of sensitized patients? A patient like yours, what is the published literature saying on that? What is
Sir,
the outcome? Despite desensitization, what is 1 year chance of acute rejection, 5-year chance of loss of graft in these patients?
Sir, the outcome for desensitized patient is not good, sir. The 5-year survival rate is around 75 to 80%, sir.
75 to
That's
80%
huge.
is which published series are you talking about?
Sir, I'm not sure.
Very good.
Yeah, I thought
Yes.
Montgomery is the guy who has published this literature, and their outcome, if you look at this New England Journal of Medicine, I think it's 2012 or so. I think the 5-year,
2011, yes.
2011 or so. So the 5-year graft survival is about less than 50% or so,
Yeah,
and the chances of rejection are around again 50%, 40 to
50%.
50% getting an acute antibody mediated rejection in 1 year time. So that is the outcome of sensitized patients who are desensitized and done transplantation. Why are these outcomes so poor? What happens? Why is it
Sir,
that?
they are at they are first because of memory cells. They are at increased risk of rejection in the post-transplant period. Also, their cumulative immunosuppression dose is very high. That results in increased infective complications.
Yes,
Yeah.
yes. So they are at very high risk of infective complications. And then because of the memory cells, the moment you reduce these antibodies, the moment you put a kidney again, because of the anamnestic sort of the moment they identify the antigen, which is to which they have sensitization, they will form these antibodies again. And you may have multiple other antibodies also which might come up.
Yes.
They may not be present in this patient, but at least in other patients, you may have other antibodies also coming up, which are donor specific. And then you have a progressive loss of kidney function in these
Yes, sir.
patients. So, memory cells, you can't abort by any treatment as of now. At the moment, there isn't much that we have at the moment.
One question that I'd like to ask the opinion of the House, the entire House. If you have an MFI of more than 10,000 to begin with, I've been under the impression that probably it's not worthwhile trying desensitization. What is the current feeling? Are we better off now, or does the same still hold good?
I would agree with you. Obviously, this will vary from, I'm sure many nephrologists would like to still go ahead because I've heard some people, but by and large, the published literature on this suggests that more than 10,000, whatever you might be doing, they will lose. So you must always, if you indulge in transplants with antibodies more than 10,000 or so, or multiple antibodies, which total amount may be about more than 10,000 or so, I usually would not transplant such patients and would avoid it because this leads to huge expenses and poor outcomes. And whenever whosoever indulges in these kind of transplant, I think it's very important to tell the patient as to what the kind of outcomes they are expected, what the kind of funds and the finances that are going to be expected, because the treatments are going to be extremely expensive. They're going to be done in the hospital costs are going to go up as well, and they are going to have repeated rejections in these kind of patients. So these will require huge funds. So I personally would agree with you that I would not want to transplant. I can always send them to a good friend who is wanting to do these transplants.
I totally agree with Professor Kher and Professor Sakhuja that it's a very risky and high cost procedure. It's
Sir,
better.
would you try a paired exchange as paired exchange has started?
I know that's. I think now I'll request you. I think we have exceeded our time. It's already 7:23. I'll request you to proceed if you discuss this case. You have got 25 minutes with you.
Yes. So my screen is visible?
Yes, make it full screen.
Yeah, sure. Good evening, sir. So the first question that whenever we pick up a transplant, that what is the native kidney disease and what is the long-term outcome of that transplant? Because I am going to convince the patient that he needs transplant and outcome is good. So PKD versus non-PKD, mostly the teaching goes that better long-term graft and patient survival. Among the transplant groups also, we all know transplant is better than dialysis. And non-PKD versus PKD also, they can have an age of better long-term graft and patient survival. And after all adjustment, death-censored graft survival is probably lower risk of graft failure. Graft survival is better. So, and as it is highlighted nowadays that CNI use must be appropriate, there should not be any misadventure from physician's part also for temptation of CNI minimization and promoting HLA match either by near relative or by KPD we can think of. And pre-transplant coronary artery disease and obesity is another issue in these PKD patients, as already there is an alert set by KDIGO in PKD management. Obesity is the big offender. So these two things also should be taken care of. And as Pratik has mentioned, that we should look for the pre-transplant extrarenal complications so that we can address the complications truly. This is the Wisconsin University Database Registry, which had shown that one important question, these are the use of CNI and avoiding HLA mismatch, all are there. And what they have additionally told, which we had discussed quite a lot, that is nephrectomy at time of transplant is unlikely to put the patient in higher risk. So nephrectomy can be done there by their opinion when space or severe hemorrhage is a problem. But what Mayo Clinic states that they have changed their practice of doing open nephrectomy to hand assisted laparoscopic nephrectomy since 2008, and they have also shifted to post transplant nephrectomy if at all nephrectomy is required. They are they think that the hemoglobin is maintained better in post-transplant period. That is why they have shown in this picture that the patients requiring PRBC is relatively more in the pre-transplant period. That is one important thing. And hemoglobin before and after nephrectomy, both is better in the post-transplant nephrectomy. And long-term outcomes of nephrectomy, pre-transplant and pre-transplant disadvantages are, they have highlighted this allusensitization one, that they have accepted also in Mayo Clinic. They have seen this thing and they decided that they should not go for. And it also renders the patient anephric, which was a concern raised by Sakhuja sir, and renal replacement therapy, which can be deferred in ADPKD patients for good urine output, can be need to be hastened. And also two surgeries concomitant is better in that way. Whatever you do, it is unlikely, if a good surgeon is with you, it is unlikely to affect the outcome. Only thing is that some people are in favor of doing it post transplant. So this is the number of in the picture is from Mayo Clinic picture. It's a nice picture showing pre-transplant had been used to be pre-transplant used to be more up till 2008, and now it is post-transplant. Pre-transplant nephrectomies were more here, and now the post-transplant nephrectomies are more. So, are sensitized patients better off with a desensitized transplant or waiting on dialysis? This was a question that haunts every time a transplant physician or nephrologist. So, in US, we have this priority-based kidney allocation system, where the sensitized people get a priority over others if they do get a matched kidney. There is an acceptable mismatch program as well. People have tried experimenting both together, the kidney allocation and acceptable mismatch. It is tried in Europe more, and some countries do try these two together. And then desensitized live donor is the policy which some institutes do practice, and Pratik's institute is one. So, who are the patients who can be benefited? All kidney transplant candidates who have more than 99.9%, they have reduced transplant rates on deceased donor list. It is from the US guidelines. It was from Shane Stock's article. Shane Stocks, who wrote the 2019 American Transplant Guideline for treatment of ABMR and desensitization. And kidney transplant candidates more than CPRA 98% and more than 5 years waiting time, which definitely shows that they are likely to have a poor outcome on wait list. So these are the patients, and also who have an approved living donor and CPRA more than 98%, but have not have a compatible offer through kidney paired donation. So more than 90% available living donor, we can do the desensitization to increase transplant candidates' access to transplantation and reduction of CPRA, to decrease known DSA prior to a planned positive cross-match transplant, to reduce the risk of immediate graft loss, which has happened with this patient that we are discussing. These are the current desensitization protocol people are using, of which these two have been used in this case of patient along with rituximab. Yes, obinutuzumab is trying to replace rituximab in various scenarios, and also the proteasome inhibitor bortezomib has been tried, but without much popularity for it. And daratumumab, which is the bone marrow plasma cell depleter, that has also been tried. And cysteine proteases, interleukin 6 blockade with tocilizumab or receptor blockade with carfilzomab has already been tried. Various people who had worked for it and published has been mentioned here. Due to time constraint, we are not going into detail. So whether we should transplant a highly sensitized patient. So these are the scenarios. The first large single center analysis came from Montgomery, which is a single center one, 211 desensitized patient, and he showed that there is relative benefit. About 50% grafts are surviving till the year 5. So after that, there came this study, which is a multi-center study on 1025 patients, and all big bosses are there in this study. There are and what they have shown, they have divided the recipients into 3 groups. Those who are flow cross match positive, those who are CDC positive, and those who are uh, Luminex positive, sub DSA positive. And as we can see that survival percentage is better with flow cross match positive patients than the patients who are surviving on wait list or waiting for a transplant to be offered or are decided to stay on dialysis. So people who were transplanted, they did somehow better than the people who were on wait list. Or this happened same with positive flow cross match, with positive CDC cross match, and with positive Luminex cross match, and also with the overall survival. Also the upper curve was better with the uh, uh, desensitization transplants. So people have accepted that it is possible that good outcome can be given to some patients if we consider that survival of at least 50% is better, and if we keep the comparator 2 groups, survival on dialysis and survival on awaiting for kidney transplant and getting transplanted. These are the 2 groups which were used in comparator, and then the outcome was shown better in the highly sensitized patients. This was also a very well-known study from Celeres et al., who identified that even they had not collected the biopsies from centers who do sensitized transplant. Then also the common causes of is it is not the CNI toxicity, rather it is chronic ABMR, which has changed the practice altogether from a practice of CNI minimization to CNI optimization till the end stage of the graft life. So chronic ABMR is the leading cause, followed by recurrent glomerular diseases. This is around 63%. And from these biopsies, we have learned direct T cell rejection probably doesn't lead, is now no more a major cause of graft failure. Rather, ABMR is the major cause of graft failure, that to chronic ABMR. T cell rejections can prepare a base from which the DNDSAs can develop, but they probably directly not lead to graft failure. So chronic ABMR, recurrent glomerular diseases, IFTA from various reasons, and PVN nephropathy became the cause. This is the time versus rejection graph, which has been shown by this study. I'm not going into detail because the time would be more. So let index biopsies more than 1 year frequently displayed donor specific HLA, particularly class 2 microcirculation changes like which has given importance to the biopsy finding of MVI, glomerulitis, glomerulopathy, capillaritis, capillary multilayering, and C4D staining. T-cell mediated rejection hardly occurs after 1 year and rarely leads to graft failure. 63% late kidney failures after biopsy were attributable to AMR, which may be C4D positive, negative, or probable. The clinical history usually revealed non-adherence. The particular patient that Pratik is discussing has another episode of rejection, which is chronic ABMR now. Probably might be that the maintenance immunosuppression he was not very stringent with. His previous history is also a history of multiple non-compliance episodes. So might be with immunosuppression also, when he was back home, might have done some non-adherence. So iatrogenic CNI minimization by us or non-adherence, usually the clinical history. So further prospective study from the same group in indication biopsies documented the same thing. So we can skip this, and ABMR is caused by anti-donor specific antibodies, anti-HLA antibodies. DSA with ABMR can occur in patients without DSA at transplantation, but who develop de novo DSA. So ABMR due to de novo DSA or pre-existing anti-HLA. We usually avoid pre-existing, but sometimes this post-desensitization residual, as we have seen, and the serological memory came back from the immunological memory, that the post-desensitization jump in the DSA and another ABMR episodes. Sometimes pre-transplant, some epitopes which were masked earlier, post-transplant, they become unmasked. So what is the outcome? Dr. Kher and Professor Kher and Professor Varma was asking for the outcome with different types of DSA. Yes, there are evidence. Multiple researchers have shown that the DNDSAs had particularly worse graft survival. The graft survival of patients with DNDSA patients versus those without. The red line is the DNDSA. And when this one is renal dysfunction plus a no de novo DSA, and when de novo DSA is there, doing worse. And when the graft C is the graft B is graft survival of pre-transplant HLA. This one is the pre-transplant HLA, which has fared much better than this one, which is the DNDSA, and significantly worse outcome happened with the DNDSA. So pre-existing outcome versus timing and outcome, pre-existing comes much earlier and DNDSA comes much late in the picture, usually more than 1 year. We can expect them after 3 months, 6 months in badly sensitized patients, as happened with our patient that might be de novo DSA related or related chronic ABMR has happened. And this is the graft where CG negative pre-existing DSA, CG positive pre-existing DSA. This is the bold red line, which is CG negative pre-existing DSA had done much better. The broken line, CG positive pre-existing DSA, little worse. And the other two are, the bold line is the CG negative de novo DSA. We know when there are chronic changes, the outcome is even worse. CG negative DNDSA had done little better, and CG negative DNDSA have really done worse. So what are the determinants of graft loss? At the presentation, if the EGFR is too bad, more than 60 versus less than 30, if the proteinuria is higher, if the pre-existing DSA by characteristic, pre-existing DSA which we were talking of, and transplant glomerulopathy, low versus high. If the CG score is high, also the grafts do worse. So ABMR from anamnestic response, if we try to do without a pre-existing DSA, that then also through anamnestic response in first 3 months, clinically severe but well responding to therapy, we can have. So the second phenotype is the persistent DSA after desensitization, which had probably happened in the first ABMR for our patient. First 3 months may be mild to moderate or subclinical, detected on for cause or protocol biopsies. In our patient, it had gone to rise of creatinine and was detected, and may respond well to the current therapy of plasmapheresis and IVIG, and DSA usually disappears. Here, the most important challenge in our scenario is the infection risk. Sometimes, while treating this, we may see the BKV, we may see the CMV, and we may see multiple bacterial infections, which may be also very difficult to fight, and fungal infections really take us to a very bad outcome if they do happen. And ABMR from de novo DSA, it may happen in unsensitized patients also in sensitized patients when they pass on over time, may be mild to severe, can have preceded by a T-cell mediated rejection, and usually does not respond to therapy well. Probably the type 2 DSAs, they are more type 2 DSAs, and these are resistant to plasmapheresis, likely to become chronic, and the DSA keeps on persisting. So this is the time-based chart, and you can see that even if sometimes we become successful in eliminating the DSA, the complement activation is there, and the NDATs are also active, and all these endothelial injury, and it doesn't go absolutely abated. The graft vessel arteriosclerosis goes on, graft arteriosclerosis goes on, glomerular transplant glomerulopathy comes in, and the IFTA comes on, and ultimately they land in the chronic ABMR. So the functional course of acute clinical ABMR, sometimes, as it happened with this guy also, and progress to graft dysfunction, and this time we are not seeing the biopsy, we may see CG positive or CG negative chronic ABMR. Sometimes the unrecognized TCMR can also progress to DNDSA formation, de novo DSA formation, and there is then peritubular capillaritis plus minus C4D. Sometimes TCMR triggered AMRs are not C4D positive, glomerulitis, IFTA plus minus transplant glomerulopathy, rising creatinine and proteinuria. This patient is having pedal edema. They have not yet told us that whether the patient has significant proteinuria or not. So plus minus subclinical cellular rejection, which can promote subclinical cellular rejection, can promote the de novo DSA formation, and this subclinical injury may come in from inadequate maintenance immunosuppression, whether iatrogenic or from the patient side with non-adherence. So even if we successfully treat, need to maintain the thing carefully. We should be careful about CNI toxicity, but when required, we may supplement with mTOR eyes and not taking out CNI, but we can to some extent minimize it, and we must try to maintain the level of tacrolimus level of 5 to 7 if we want to have a good maintenance immunosuppression. So, so this is the difference between the early and late AMR, which has already been discussed, and treatment of ABMR depending on the cell types we have mentioned here. In the initially, we can use pulse steroids, thymoglobulin, belatacept, then to target the B cell, because B cell, NK cell, and plasma cell, particularly long-lived plasma cell recruitment, is very important for memory released DSA. DSA released through memory. So all these have been tried, though Botiject trial have shown that there is not much benefit. Some people still, I was looking at the Delphi study from ESOT, where some people still uses bortezomib, though 70-80% use rituximab, and almost universally more than 90% in that Delphi study agreed that they have used this one for plasmapheresis and IVIG more than 90%. And some people have started using eculizumab, and tocilizumab have been used by more than 60-70% people on top of it. So treatment regimens, standard of care is plasmapheresis and IVIG. High dose IVIG is often used when particularly in institutes where they practice it as protocols. They claim mixed evidence is there of its added benefit of rituximab and this high dose IVIG. And these are the evidence for use of plasma exchange and IVIGs. The studies may help the students to go into detail. And sir, I would like to stop here because I probably will be crossing my time limit. So, how this discussion may change our approach? Promotion of CAS and KPD policies, individualization of CNI minimization policy in long term, screening for DNDSAs, we can make it a practice, particularly in highly sensitized patients. When we are looking at, we can continue the screening every month and accordingly hike up the immunosuppression, promoting electron microscopic input to look at the chronic glomerulopathy, treating the comorbidities aggressively, particularly hypertension and DM, particularly in CG positive patients. These are very important because non-immunological issues are also to be addressed nicely. And plasmapheresis, IVIG, standard of care, addition of Ritux or IL-6 inhibition, cost, infection potential versus benefit. Every country might have to follow their own guideline depending on the resources and the individual scenario. Thank you, sir.
Thank you very much, Dr. Arpita. Wonderful. I think you have briefly summarized whatever was relevant to the case, and you have already given an idea that there is data that in Western world that possibly sensitized transplant, we can go ahead, but at a cost of too expensive and the cost of infections which can occur. But it is possible. And you have also mentioned that if you are at all going to do it, it is very pertinent to have proper adequate immunosuppression, keep a watch on what is happening by doing donor-specific antibodies, de novo antibodies, that every 3 months monitoring is required. I think very optimum and excellent. And there are questions
One
from
question.
audience. I am coming to Professor Girish Narayan. He is there. Please, Professor Girish Narayan, first you.
Now, thanks, Dr. Arpita, for a wonderful discussion. Now, but I have a small basic doubt I would like to ask Dr. Amar Singh. I heard he was getting only 500 milligrams BD of MMF. Do you think this was an adequate dose for such a sensitized individual? We talked about adequate immunosuppression. I just want to ask the panelists and other members, what is the usual doses of immunosuppressive drugs? What level of tacrolimus we should maintain? And what is the adequate dose of mycophenolate in these type of cases? Because we tend to give relatively lower dose of immunosuppressive drugs for our patient, presuming that our Indian patient require a lower immunosuppressive therapy. But especially in these type of cases who are highly sensitized, how do we monitor and how do we adjust the immunosuppressive drugs in such cases?
Sir, for our patient, he was in the follow period, he was having recurrent urinary tract infection, in view of which his mycophenolate was reduced from 500 mg thrice daily to 500 mg twice daily.
What should be the TAC level? Professor
Sir,
Girish has asked.
TAC level in the first 3 months we target around 8 to 12, and and then 6 to 10, and after 1 year.
In this particular case, composite monitor. That's why I just wanted to know. Any
Sorry, sir.
idea about in this particular case, did we achieve a good immunosuppressive dosage for him?
See what Professor Girish is asking, that tacrolimus, he's past 6 months post-transplant,
Yes,
isn't
sir.
it?
Yes, sir.
January he was transplanted, and he is a candidate who suffered from ABMR.
Yes, sir.
That was in April, which month?
No, January itself.
Sir, January
January
8th, sir.
itself.
Yeah.
He has on 6/7 post-operative day. So he suffered ABMR. So he's a high-risk candidate. Logically, if he's in 6 month or 8 month, I will like to maintain his TAC level around 6, 7, approximately that. And MMF, as a protocol, we generally, if by 6 months, we try to bring it down to 1 BD if there has been no rejection and patient has been doing well. Possibly this patient had a history of rejection,
Yes.
so you will have to think that should we reduce MMF or not. Professor Sakhuja, sir, your comment.
Yeah, one question in my mind. I've seen recent literature mentioning the use of anti-CD38 monoclonal antibodies for treating ABMR. So could we consider using daratumumab in this kind of situation? Obviously, the cost will be another consideration.
No, sir. The whatever studies that has been done, it is not very much effective for the desensitization. For chronic active
No, no,
ABM,
I'm not talking of decent. I'm talking of treatment
ABM.
of
chronic,
ABMR.
then in that case, we have to do the CD38 positivity or not in the biopsy specimen.
Yeah.
If positive for 38, then it will be very effective. They have initial studies that is very encouraging, and that can be utilized. But if the CD38 negative, then in that case, it will.
Yeah.
Actually, sir, probably we will be targeting the long-lived plasma cells in bone marrow, which are releasing the DSAs in the circulation. So, 38 positivity of the plasma cells, that has to be looked at, and then anti-CD38 would work.
And this is also difficult balance, because whether in a sensitized patient, they are already cumulative immunosuppression is pretty high. So whether to continue with a high dose of immunosuppression to avoid rejection or to avoid infection in those situations, this balancing is very difficult, particularly this patient. They have already received a quite high amount rituximab, plasmapheresis, treatment of ABMR. So their immunosuppression level is high. So over and above that, it will benefit to the patient, a little more harm to the patient. Recently, we have started this using these viruses, because the stack level testing is not very much reliable nowadays. So virus, that can give an idea regarding the patient overall over immunosuppressed or an under immunosuppressed. And we have now adjusting the immunosuppression accordingly as by assessing the immunosuppressing level. They give a value of, say, log between 6 to 8. And if this is more than 8, then you can see that the patient is over immunosuppressed. And if the value is less than 6, then is under immunosuppressed. So we can adjust accordingly the baseline immunosuppression. Otherwise, it is very difficult sometimes. It is sensitized, it is high.
Any center doing MMF level now?
I don't think so. I only think CMC Vellore was at one time doing them.
Dr.
doing
Sean was doing that time.
Yeah.
That was around
Nobody
20
else.
years back. Yeah.
Mm.
Okay.
Nobody else.
Because from the audience, there were many questions, but I think most of the questions we have answered. The questions were that nephrectomy itself causes hypersensitization, why nephrectomy was done, what was the indication for patient to undergo bilateral nephrectomy. Third was why bilateral nephrectomy. If CDC cross-match was positive, is it worthwhile to go for transplant? Highly sensitized recipient, it is better to go for KPD than desensitization. And I think we have covered most of these points. And I think the student Amar has done very good job. I think his presentation was very good and he was updated to what he was saying. The Dr. Pratik, as usual, discussed the case very well, and Dr. Arpita was gave a masterly talk. I will leave here to Professor Sakhuja to wind up and to give the final comment.
Just one comment, Dr. Varma.
Yeah, please, Dr. Anuradha, please.
I believe CMC does MMF levels even now.
Okay.
That my colleague was saying.
Yes,
Yeah,
yes.
somebody did mention that all of us, none of us is doing as a standard. We start giving 2 BD to everybody, irrespective whether the person is 50 kg or 80 kg. This is a blind procedure. If I remember, Dr. John once, I think in ISN, he was talking of MMF level, and that is the time he was saying that the ideal is between 30 to 60. And he says 1/3 are in the ideal range, 1/3 above, and 1/3 were below the range. Professor Sakhuja, that is what he was mentioning.
Yes, that is true. That was a long time back.
Long time back.
Yes.
The standard dose, what we were practicing.
Yes.
Anuradha
So,
ma'am, nice to see you.
right. So, my final comment is probably the same as what I started with. So, I think when you have such a highly sensitized recipient, one needs to warn the patient and his family in advance that they should go ahead with the transplant only if they are prepared to face all the complications that we have discussed today, and provided they have the financial means to support the therapies that are likely to be required. So, the nephrologist needs to be very careful when embarking on such a transplant and should carefully select his patients while doing so. So I think that would be my final comment.
Dr. Pratik, your any comment?
No, sir. Basically, yes, it is always there. If you have sensitized patient, more chance of infection, more chance of rejection. But then we have to compare then what in which they will be. They will be under dialysis. They will do worse. If the KPD program is very active, or you can accept their acceptable mismatches. If they are practiced, then definitely this is better. But thing needs to be clear that for a very much highly sensitized patient, more than PRA 98%, waiting for 3-4 years, KPT is also very difficult. It is not very easy for them. Probably if imlifidase comes, then this kind of patients may be taken for the transplantation in a simpler way.
No, I agree with you. What you are saying is that some centers have to take this risk also. And people who are keen to have transplant, as Professor Sakhuja said, once you have explained to the people that these are the risks, this is the cost involved, there are some who are still keen. I have got a similar patient sitting who is from one of the foreign countries and a very extra rich man. He wants to stay in suite only. He said, I can't stay in the room. And you explain, he said, money is not a criteria. Please go ahead. So there are people like that. You have to explain, tell the risk. But if somebody is still keen, that yes, one has to go for that. And the risks are known to us. Dr. Arpita, your comment before we wind up.
I have learned a lot. I have enjoyed the presentation of the student and learned a lot.
Thank you very much. Any other question? If none, Professor Sakhuja, with your permission, can we close the session then?
Sure. Yes.
Thank you very much.
It was nice to see all doyens together.
It is all. Thank you very much, Pratik. Thank you very much, Arpita. Sakhuja, sir, pranam, and thank you very much. I think Dr. Kher has left in between. And thank you, Dr. Anuradha and Dr. Girish Narayan for joining. Over to Puneet.
Thank you so much, sir. With such wonderful discussions by our senior faculty, this was again a true masterclass which students will always look forward to, sir. Thank you and good night.
Thank you.
Thank you.